We move to the next session. We invite the chairperson, Professor Ayman Yusri, Professor Maha Mohsen, Professor Rasha Rifai, Professor Rifat Kamil, Professor Hani Dabbous, Professor Mustafa Shazli, Professor Rasha Samir, Professor Sharif Nagawar, and the moderator, Professor Nagla Zayed. تفضلي يا دكتورة نجلا.
Good evening, everyone. Sorry for being late. Dr. Gish, hello, how are you?
Thank you. Good evening.
So, Mr. Chairman, my dear professors and colleagues, first of all, I'd like to thank Professor Zakaria for giving me the opportunity to be a moderator in this great session. It's really a challenging thing to have two topics, hot topics in this session about transplantation and the COVID. So it's by the end of the day, it's really at the end of the day, but I hope it will be an interesting one. So the following session will be about the liver transplantation in the era of COVID. So Egypt is expecting the third wave of COVID these days, the COVID pandemic. The fear of ease in restrictions and the ignorance of preventive measures could make this wave more strong even. However, at one end, the Ministry of Health and Population has launched a mass vaccination campaign, but at the other end, we don't really know how effective the vaccination is. The impact of COVID on the cirrhosis care will delay a lot of transplantation procedure. The elective ones, more decompensation in liver disease patients will be seen, more accumulation of patients on the wait list, more dropouts and mortality on the wait list. So it's really a challenging part. So resuming transplantation during the pandemic is really a challenging issue. The risk of donor-derived transmission, how reliable the diagnostic tests are, the healthcare resource utilization, is there a capacity in the health system that can accommodate this pandemic, and the preventive measures, if the vaccination or not. So it's really my pleasure to introduce the coming speaker, Professor Dr. Robert Gish. He's the medical director of the Hepatitis B Foundation, professor of medicine, Loma Linda University, professor of internal medicine in the University of Nevada, Las Vegas, Reno. He is going to give us a presentation about resuming liver transplantation during the COVID pandemic. Actually, I have known Professor Gish since 2008, and since then, we are doing a lot of work together. So Professor Gish is really an eminent professor in the field of hepatology with a lot of international peer-reviewed publication and a member in the editorial board of a lot of journals. So Professor Gish.
Shukran, marhaban. Thank you very much for having me. I will now move to sharing my screen. Just one moment, thank you. Nagla, for this incredibly nice invitation and wonderful introduction. Are you able to see my screen? Everything okay?
Yes, we are, thank you.
All right, and thank you very much to the chairpersons also. And this is part two. I gave a sort of a first level presentation about liver transplantation in the COVID pandemic and changed the title slightly, updated this to what's happened in the last 5 to 6 months, and also looking back over the last 15 to 18 months. In the US, we are fortunate to have broad-based vaccination. We've had 100 million people vaccinated in the last approximately 10 weeks, and looks like we may reach 200 million doses by May. So we are seeing a big drop in our infection rate, a reopening of our economy, businesses, et cetera. And I'll talk about the effect on transplantation as I build into some details. I don't have any relevant disclosures. This is an updated from Johns Hopkins just a few days ago, just talking about the global effect. Of course, we've seen new waves of viruses from South Africa, variants from Brazil, New York, California moved through. There's an announcement that the Brazilian variant was in San Diego starting yesterday, which is where I live and work and have my base. So things are changing rapidly. We must keep our guard and our safety up to the highest level. This is trends in solid organ transplantation this last year. This is actually just data up through last May, but as you can see, there's a very prompt rebound after the first wave took place in many countries as centers did their accommodation and management. I'll talk about what those details are, but what's very, very important is that a number of centers shut down completely. Most of the transplant centers have reopened with a variety of mitigation techniques, which I'll be talking about today as well. Live donor liver transplant programs are reopened at most centers also, both because of precautions that have taken place, testing, antiviral therapy, social behaviors that have changed, and most recently, vaccination. I'll talk about some of these advances in detail. The biggest message I have about the US was this transplant trends that took place. This is data up through last September, but I'd just like to have your eyes point to the upper right-hand corner. This is one of the busiest years in terms of number of liver transplants in the US, where we came up to about 8,500. This is a mixture of operational changes that took place at transplant centers, and sadly, because of the opioid epidemic, we've had a marked increase in overdose, brain death patients, and subsequent donations. Donor recipient screening has advanced substantially. I'll talk about this in more detail, but I want you to keep this algorithm in mind as you're managing a transplant center. I'll represent this slide in a little bit different format at the very end, but we're looking at living donor and deceased donor, working through protocols, timing of liver transplantation, timing of testing, and using the most advanced tests. And we'll get into some more of the details now in a moment. So COVID testing has undergone major advances, although we still have basically two branches of testing. One is the rapid testing, which is looking at viral proteins. And we have PCR testing now that includes rapid PCR tests. There were some major bumps in the road with false positive and false negative issues at the beginning of these test releases. Most of the tests are still under EUA, emergency use authorizations, and haven't reached full regulatory clearance in either the US, Europe, or other parts of the world. I'm assuming including Egypt, although the test accuracy has improved markedly. Under the EUA screening process with the regulatory agents, many inaccurate tests, low quality tests have been rejected, have been closed, and the tests that we have today have sensitivity and specificity rates that are far in excess of 80%, although you need to look at the specifics of the tests that you have on hand. I want to talk about staffing for a moment. Of course, we have challenges with employees being infected, employees having challenges with their own family, travel status, units that had to move from general units to specialized to COVID units, and then moving back to managing patients with end-stage liver disease or managing transplant patients. Rapid testing for employee by PCR and antigen testing is very often being used. And of course, antibody testing I'll talk about in a little bit more detail. But vaccination should be implemented for all medical staff as early as possible. And of course, you need to follow the protocol, whether it's a single dose vaccine, such as the Oxford AstraZeneca, or dual dose, such as the messenger RNA-based vaccines, or the vaccines also that are coming from Russia and China. Visitation policies have to be managed in direct proportion to infections in the community and risks and benefits for both the patient, the recipient of the transplant, donors, and support. One of the items that we are discussing globally, not just for medical management, for travel, work environments, is whether individuals need to be carrying an immunity card, a vaccine card to document their vaccine and immune status. That's something we need to be thinking about in terms of policy changes. Limiting visitors, rapid testing of staff, frequent testing of staff, sometimes as much as 3 times per week, has markedly mitigated infection risk. One thing that's been highlighted in the research just in the last few weeks is that 2 to 3% of individuals account for over 80% of coronavirus transmission. So there apparently are these super spreader individuals, super spreader patients or family members. And it's not easy to predict exactly who those are because we don't have ways to quantitate the amount of viral shedding that's taking place in individuals. But broad-based safety measures are still the standard and are being implemented much more thoroughly globally, thankfully, with better leadership. We do want to protect our living donor. I know in Egypt, this is the primary method of liver transplantation, informed consent for that donor, COVID testing at least 7 to 10 days prior to the procedure, and again, 24 hours prior, using both PCR and rapid testing. I'll talk about some of the critiques about PCR testing in a few moments. COVID-free operating rooms, ICU, ward rooms also are very important. There's still asymptomatic exposure, and that's why screening or minimizing patient exposure to other individuals outside the medical staff is very important. This is an incredibly important graph, especially now that we have the ability to measure antibodies. We have 2 different antibody tools that are present. One is to the spike protein, and the other antibody is to the nucleocapsid. This is an important immunity test, and I'll talk about that in more detail in terms of titers, protection, and relevance to plasma after infection. PCR has a number of problems because a PCR positive test does not mean that a person still is carrying full-length viruses. PCR detects viral fragments. So we understand now that PCR positivity may lag out 2, 3 to 4 weeks after an infection has resolved. So you need to be closely monitoring signs of infection, symptoms of infection, and once a patient becomes asymptomatic, afebrile, infection markers such as pneumonia have resolved, it's most likely that PCR testing is going to be inaccurate in those individuals. We've learned recently that viral shedding in the stool can take place for many, many weeks to a month or 2 after infection has resolved. Antigen testing is very, very important. These are point of care tests, 20-minute turnaround. They detect protein fragments. They're very specific, but not sensitive. That's one of the challenges. So there is a risk of false negative tests. So you need to, again, combine this with timing of signs of infection, symptoms of infection. This persistent or intermittent PCR positivity needs to be matched with signs and symptoms of infection as well. It's very difficult to isolate replicating viruses more than 9 days after symptom onset in immune-competent individuals. So our repeat PCR positives, persistent infection, viral fragments, or reinfection. Again, this has to be matched with symptoms and signs. If there is symptoms of reinfection, there's now strong recommendations that those viruses be sequenced to help determine if they have one of the new viral variants that are spreading, including the UK variant, which is one of the first ones that spread and is now dominant or semi-dominant in the US. This is very important research, both looking back 10 years with Ebola, SARS, and MERS, which had a distribution droplet of airborne of about 3 feet. COVID-19 is between 3 and 6 feet, and measles can be up to 20 feet. This is very important historical research and also in terms of policies that are taking place today. This is a study of about 251 eligible school districts, over 500 students, 500,000 students, over 99,000 staffs. This is over a 16-week study period. Very interesting in terms of 3 feet and 6 feet of physical distancing, and also in terms of using PPE. You can see from this graph, the 2 orange/yellow bars are the student case rates of infection using 3 feet versus 6 feet. That 3 feet had the same case rate per 100,000. This led to a major policy change in the US in terms of school reopenings, and it's also going to be guiding a lot of other interactions in the medical care setting as well. It is possible that students are less infections, have less viral load. That's research that's pending. So it looks like a 3-foot interval with mask wearing is probably sufficient for a number of our educational and potentially medical environment. I want to make sure you look at this graph also, looking at distance, but this graph is slightly different. This is in meters. So the 3-foot mark is the single one. If you have a high baseline risk for infection, you still need to be thinking about 6 versus 9 feet in terms of social distancing. But in the intermediate to low baseline risk for infections, 3 feet is probably sufficient. And this needs to be highlighted, that needs to be in combination with PPE. Behavior changes hasn't, this advice has not changed, although I'm going to say that white coats, ties, handshakes are probably going to be out of the social environment for quite some time, maybe indefinitely, at least in the medical care setting, because of risk of transmission from fomites and hand contact. Practice changes to prevent nosocomial here is very interesting too. We have this whole issue about patient masking and recent advice for double masking in high-risk environments using a combination of a surgical mask with an N95. Aerosol generating procedures are everywhere. So these are higher risk settings, and of course, higher mitigation strategies need to be implemented. Let's switch now to talking about the vaccines that are taking place. This is a really important publication about the safety and immunogenicity of the 2 mRNA COVID-19 vaccine candidates. I was fortunate enough to have my first Moderna vaccine right around December 28th, and the second dose in late January. And 8 weeks later, I had my neutralizing antibodies for the spike protein measured at greater than 100. That's the maximum test limit from the Quest test in the United States. But these antibody tests will be very important in a number of clinical settings, including your pre and post liver transplant patients. I'll talk about that more in just a moment. What about protection after infection from SARS-CoV-2? Is having an infection basically the clinical equivalent of having vaccination? And it looks like it's quite similar. The far right column gives you an estimated protection of about 80% after having an infection, a primary infection with SARS-CoV-2. Reinfection rates during the second surge that was published in this manuscript just a couple of weeks ago was very, very low, under 1%. And rate of new infections during that second surge was also very low in the 3% range. This also gives you some information about age. And I use this age as a bit of an equivalent to our patients with cirrhosis who have a relative level of immune suppression. And of course, our post-transplant patients are directly immune suppressed. And I'll talk about some data there in just a moment. This is an age-based study in Denmark. This is assessment protection against reinfection. These are PCR tested individuals. And the protection rate here is in the 47% range. So there is protection at 80%, but that falls off in individuals over age of 65. I'm expecting similar information or protection in our patients with cirrhosis. What about these neutralizing titers and vaccine protection? These very complicated graph, but basically this is a vaccine response relative to convalescent plasma looking across a variety of different vaccines. And what's good news here is that at least the 2 mRNA vaccines plus some additional vaccines had a higher protection rate than what was the antibody level in convalescent plasma. So convalescent plasma is being used to moderate outpatient disease in the US and various parts of the world. And vaccine protection looks to be better than convalescent plasma. So I think these are very, very important graphs. This is information that also was just published a few weeks ago. What about giving a single dose? There's a lot of activity going on, especially in the UK, that the single dose vaccine has really bent the curve, and follow-up dose for 2-dose vaccination strategies may be stretched out 8, 10, 12, 14 weeks or longer with similar or maybe even improved rates of protection. This is a study that was just published this last week in solid organ transplant recipients. There were over 400 patients here, all PCR negative or history of negative COVID infection, age in that 55-year group. This is primarily Caucasian patients. Part of the patients received the Pfizer, the other half received Moderna vaccine, about 6 years post-transplant. But look at the amount of immune suppression here. 83% are on tacrolimus, which is baseline, but over half were still on corticosteroids, which is very unusual in my opinion. Most of my patients are off steroids by 6 months. Mycophenolate, over half, nearly 2/3 of these patients. This is a lot of immune suppression with occasional use of azathioprine and the mTOR inhibitors. At a median of 20 days after the first dose of vaccine, we only had a 17% antibody response. So clearly, I believe in these solid organ transplant patients, we're going to need to have 2 doses. And now there's discussions, as you've heard over the last week, about giving a 3rd dose or updating people with a 3rd dose with a modified vaccine that many of the companies are working on, including AstraZeneca, Pfizer, Moderna, and other individuals, as these mutant viruses, especially the Brazilian virus and South African virus, which may have lower protection from the current vaccines that we're using. The anti-metabolite drugs appeared to be the greatest association with a reduced response. So if you can, in your post-transplant patients, reduce their immune suppression, of course, taking into account risk for rejection. Liver transplant patients, we have untreated hepatitis C, advanced liver disease. These patients were not included in these clinical trials. This liver transplant study I just showed you is the only study that I could find recently. And we need to have really good data in our cirrhotic patients with a gradient across their level of liver dysfunction, and also post-transplant by time and by level of immune suppression. So in summary, we really need to be thinking about the benefit and risk of liver transplantation in our patients in the COVID time, monitoring patients closely with testing, using social distancing, using PPE, using closely managed inpatient programs as well, and also looking at their underlying risk. As you know, patients with obesity and metabolic syndrome have not just a higher risk of infection, but most important point is about a higher risk of more aggressive and complicated COVID disease. There's a lot of different tiering that has taken place in terms of maintaining liver transplant service, and I would refer you to these references. Maintaining a service is very important. Going back to screening, testing in the US, testing has dropped nearly 30% in the last 8 weeks. The focus has been on vaccination, but we're very concerned that under-testing is going to underestimate disease, and we may have another either flattening or a follow-on surge of infections because of lower testing rates. The last few slides are from the AASLD best clinical practices that were just published. I'm not going to read through each of these slides because we have limited time, but I really want to focus that we need to be looking at symptoms in our patients, vital signs, screening patients with chest CT, which is being done in moderate to high risk individuals, or where you suspect infection, you may be suspecting a false negative test. Close assessment of your donors with both PCR and rapid testing is very important. Vaccination, just like we've talked about with viral hepatitis A and viral hepatitis B. I think these are very, very important steps for protecting our patients and protecting our transplant programs. Potential recipients, they are high-risk individuals and also should have vaccine applied to those individuals and be monitored with low threshold for testing and screening. Post-transplant patients with COVID-19, we're all still recommending a slow lowering of overall immune suppression, and a focus should be on reducing the anti-metabolite doses, but these should be very gradual reductions with clinical risk assessment for rejection and toxicity, with close monitoring, of course, of renal function and bone marrow status. There's NIH guidelines concerning this as well. We have a number of our liver patients who are on immune suppression for autoimmune liver disease that should be monitored or adjusted in a similar fashion as the post-transplant patients, including monitoring blood levels. You can get blood levels of mycophenolate also. Therapeutic trough for mycophenolate should be in the 1 to 3 range, and dose reduction to keep it in that lower boundary, I think, is beneficial for our patients. There's some good guidance on outpatient management of patients with chronic liver disease who are at risk for COVID-19. We did discuss monoclonal antibody preparations have been released in the US and being used only for outpatients, not for inpatient services. Be very cautious about the use of steroids, dexamethasone, only in patients with more severe pulmonary disease. NSAIDs and acetaminophen do not appear to be detrimental. They're probably beneficial for managing fever, but NSAIDs, of course, need to be used very cautiously or not at all in patients with cirrhosis. There's some really good guidelines also for inpatient with remdesivir, dosing duration. Remdesivir is hepatotoxic, so monitoring liver biochemistries, and if patients have evidence of ongoing severe liver inflammation, remdesivir should not be used in those individuals. And finally, tocilizumab and baricitinib, we just have very little data in our patients in the liver disease or transplant populations. So high level of caution and informed consent needs to take place if using those medications. Nagla, thank you again, Shukran, for having me at this wonderful meeting. I've learned a lot listening to some of the other speakers this morning, all the sponsors, and best wishes as you counter your next wave, hopefully get vaccination to your population and keep your programs as open as possible. Thank you so much.
Thank you so much, Professor Gish, for this informative, interesting presentation. So because we are very short of time, so can we have a couple of questions or comments?
Dr. Nagla, Professor Robert, it's my pleasure to meet with you again today.
Okay, Dr. Sharif Magan.
And thank you so much for this elegant talk as usual. And of course, you're always giving us the up-to-date information about COVID and transplantation. And I have a few questions I would like to ask. They're very short. You used the expression of super spreader. Are these always the immune compromised patients, or how do you define a super spreader?
That's a great question. There was a publication this last week, which I can get to the reference. I don't have the exact location right now, but they did this study on who is spreading the disease, and it appears to be highly viremic, asymptomatic or low symptomatic individuals who are accounting for over 80% of new infections. So 3% are infecting 80% of new infections. And the level of virus in their sputum or nasal swabs was extremely high. So there's some probable proportionality to the amount of virus that they're carrying, and also probably lack of social distancing and PPE.
Okay, thank you. I'll give a chance to my colleagues if they have questions, but if they don't have, I will continue as soon as they finish. So I think Professor Mustafa may have a question to you. Okay, so if you don't mind, I'll just ask another short question about, we have in our country 2 vaccines, the AstraZeneca vaccine and the killed vaccine. So our patients are again asking us which will be the preference in our state, knowing that this is an adenovirus and this is a killed virus. Is there any recommendations we can help our patient reaching a conclusion in this aspect?
I don't have much information on your second vaccine that you described, Professor Sharif, but I would say the AstraZeneca vaccine has undergone extremely detailed review. As you know, at multiple levels, they had challenges with their study design initially, half dosing in a subset of patients. And then most recently, this association with central vein thrombosis, which appeared to be an autoimmune type response. But the benefit risk ratio of the AstraZeneca vaccine is clearly in favor of the vaccine. Also, single dose appears to be quite interesting in individuals, although a second dose will probably be best. But I would just look at the data. If you don't have any head-to-head information, just look at the regulatory and reassure your patients as you understand the safety data.
Okay, thank you. Thank you.
We have a question from one of the chairpersons here.
Okay, thank you for your lecture. I would like to ask about the vaccinated recipients. They showed only 17% antibody response after 20 days. What was the vaccine and the interval from the liver transplant? Thank you.
Nagla, can you restate that for me?
The vaccinated recipients, you showed that they have only 17% response of antibody after 20 days from vaccination. What was the vaccine and the interval from the liver transplantation?
So the average time from transplant, if I'm hearing your question correctly, was 6 years. And the two vaccines used were the Pfizer and Moderna vaccines, so about 50% for each. Now, we don't have any data after a second dose, and we don't have data with any of the other vaccines. Hopefully that answered your question. I couldn't hear it very clearly.
All the recipients, 6 years from transplantation.
It was a mixture of different solid organ transplant. It wasn't just liver transplant. That's correct.
Thank you, Professor Dr. Gish, for this informative, really interesting presentation, as always.
Thank you.
It gives me a pleasure actually to present our next speaker. Muhammad Abdidi, a very dear friend and a well-experienced physician in transplantation, about evaluation of potential liver transplantation and the waiting list in the era of COVID-19.
Bismillah ar-Rahman ar-Rahim. Thanks, Mr. Chairman. First of all, I would like to thank Professor Sarag Zakaria and my dear colleague, Professor Nagla Zaid, who gave me the chance to share in this valuable scientific conference. This nice photo is a photo of wedding day of the daughter of one of our recipients, living donor liver transplant recipients that has been performed in our institute, National Hepatology and Tropical Medicine Research Institute, about 1.5 years ago. In this patient specifically, we meet medical and surgical challenges, and we were about to abort the techniques, but fortunately the operation and the post-hospital stay passed smoothly, and the patient is doing very good now, and he celebrates the wedding day of his daughter few months after liver transplant. And we hope that we can help much more patients in the future, even in presence of COVID-19. Our agenda, first, challenges we are facing: patient selection and decision for liver transplant in COVID era. What is different in preparation in COVID era? What about patient management while on waiting list? What to do immediately before operation? Challenges: there is a tremendous concern in the liver transplant community about the COVID-19 pandemic. Limited data raise questions about immunosuppression and hepatic injury related to COVID-19. The mortality rate of the disease is thought to be 2 to 5% in the general population. But when the patient is older or have other comorbidity like diabetes, hypertension, or COViD, the mortality rate may reach 50%. In a patient with previous liver disease, the mortality rate due to COVID-19 infection, if occurred, may be to 30 to 36%. COVID-19 recognizes an angiotensin converting enzyme AC2 receptor to infect host cells. So, in living donor liver transplant, in the early post-operative period, both liver transplant recipient and donor are more susceptible to COVID infection because they have an elevated levels of angiotensin converting enzyme 2 due to hepatic regeneration. So we have now the first challenge. Our chronic liver disease patient have 36 mortality if they catch COVID-19, and when we transplant them, also they are more susceptible to COVID-19 infection. Post-transplant immunosuppression may increase virologic injury and may cause more severe disease, while immunosuppression also may be protective against cytokine storm that is responsible for the more severe illness of COVID-19. But it is too early now to know if post-transplant patients are more at greater risk for more severe COVID or not. So the challenge, immunosuppression may increase mortality, while immunosuppression may be protective against COVID-19 illness. But the fact that all recipients on immunosuppression may have more intense and more prolonged viral shedding. That means that they are more effective to the contacts and healthcare workers. So this is the challenge of crucial role of implementing infection control measures to protect our healthcare workers from catching COVID-19 infection from this recipient. Another challenge is the limited resources. Should we decide who is more in need to these limited resources? مين أولى بهذه limited resources؟ العيان اللي عنده COVID-19 ولا البيشنت of end stage liver disease اللي بيحتاج liver transplantation؟ الامريكان اسوشيشن اوف ستدي اوف ليفر ديزيز من اول الكوفيد ايرا ما بدات بيطلعوا كل كام اسبوع كونسنسس ستيتمنت على المانجمنت اوف كوفيد 19 في الليفر ديزيز والليفر ترانسبلانت وبيحدثوها كل اسبوع. من جون 2020 زي سولفد ذا بروبلم. قالوا ان الاي اس دي ريكومندز اجينست بوستبونينج ليفر ترانسبلانتيشن، وقالت ان كل اريا كل كوميونتي بيحدد هذه الاولويه حسب اللوكال بريفالنس اوف كوفيد 19 وحسب حالات العيانين اللي عندهم. ومصداقا لهذا الكلام الكونسنسس ستيتمنت اللي طلعت في 9 مارس بالظبط من 17 يوم 9 مارس 2021 قالت ان حالات الليفر ترانسبلانت في 2019 بمقارنتها ب 2020 العدد يعني لقوا ان في 2019 زرعوا 8896 حاله وقصاد كده في 2020 زرعوا 8902 حاله، يعني تقريبا العدد ما تاثرش. مش كده وبس، منهم 524 ليفنج دونر في 2019 قصاد 491 في 2020. اللي اظرف من كده في الهند في الانستيتيوت اوف ليفر ديزيز اند ترانسبلانتيشن لما عملوا 46 ليفنج دونر ليفر ترانسبلانت من مارس 2020 لاغسطس 2020 وجدوا فايندنج كانت سربرايزنج بالنسبه ليهم. The most prominent finding in this study was the significant reduction in the post-operative infections in COVID-19 era. اتفاجئوا بان التوتال بوست-operative infections اقل من اللي قبل كده. وطبعا قالوا ان ده غالبا سببه مالتي فاكتوريال لان احنا في الكوفيد ايرا بقينا في عندنا مانداتوري سوشيال تيستنج بقينا نستخدمها، في هاند واشنج، في ماسك، في PPEs، فده كله قلل الجلوبال انفكشنز عن قبل كده. تاني نقطة patient selection and decision for liver transplant. مين who will be selected for liver transplantation in the era of COVID-19? Traditionally, we know that transplantation is indicated in acute liver cell failure, chronic liver disease, with complicated cirrhosis, metabolic liver disease, etc. But in COVID era, we should take the decision of liver transplant just tediously, and non-urgent transplant should be postponed. والASLD في جون 2020 قالوا we may need to prioritize patients who are most likely to die on waiting list and defer those who can wait longer. يعني تأجل اللي ممكن يستنى.
Dr. Mohammed, please can you speak in English all?
Yes, yes.
Dr. Gish.
Yes. Recipient age and mortality. The European Liver and Intestine Transplant Association and the European Liver Transplant Registry of COVID-19 has reported 16 mortality in liver transplant recipient due to COVID-19. These results suggested that the mortality in liver transplant recipient might be higher in older recipients. Above 60 years, we have 22 mortality if the liver transplant recipient catched COVID infection versus 0% in the recipient below 60 years old. In India, in high volume center of living donor liver transplant, they give us The first detailed report of LDLT activity from this center, and they also use the same criteria of selection. They select only sick patient whose survival for several months were unlikely. EASL and European Society of Clinical Microbiology and Infectious Diseases recommends that liver transplant should be restricted also to cases of acute or chronic liver failure with high MELD score and HCC patient who has upper limits of Milan criteria. Our Ministry of Health in Egypt delivered Egyptian protocol for living donor liver transplantation in January 2021. And they make priority to those patients whose mortality overweigh the possible risk of COVID-19 infection. And they classify our patient to two groups, high priority group and moderate risk group. And they say that the high priority group that have MELD score more than 20, child score more than 10, previous history of SCBP, hepatorenal syndrome, HCC unfit for bridge therapy, they are high priority risk group, and you must proceed for liver transplant with precautions. And if the patient is in moderate risk group, MELD score between 15 and 19, and HCC within Milan criteria that can do bridge therapy, these patients, you must complete the donor preparation and you can wait for close follow-up during the COVID era pandemic. We may need to prioritize patients who are most likely to die in waiting list. This statement was written by the ASL consensus statement in June 2020. But in the recent consensus statements updated in 9 March 2021, they removed this statement and replaced by "we should not compound the negative impact of the pandemic by risking the lives of patients in need of liver transplant." Third point, preparation for LTX in waiting list in COVID era. First, try to do limitation of outpatient clinic visit. It is important to assess who from our patient must be needed to meet you face-to-face according to the local prevalence of COVID-19 and the clinical condition of the patient. Consider telemedicine alternative, order labs and imaging of only clinical importance, consider accepting only grafts with low risk of delayed graft function to avoid prolonged hospital stay and prolonged ICU and delayed graft function in recipient. If your donor catches COVID-19 infection during preparation for liver transplant and the illness was mild or asymptomatic, likely to wait for 21 to 28 days after disease onset before you proceed for transplantation. Management of our patient while in waiting list. Liver transplant candidate should be managed as follows during the pandemic of COVID-19. Postpone outpatient visits and promote online consultations. Restrict outpatient visits to urgent indications only. Modification of OPD by widening the patient waiting area and following strict infection control measures. Non-urgent procedures such as liver biopsy and elective endoscopy should be postponed. Refill essential medications. Provide prescriptions for 90 days instead of 30 days supply. Caring of decompensated cirrhosis or patient with HCC must be done on the same standard. Regular updating of MELD score must be done. Also, always provide PPEs, screen for COVID-19 when necessary. When necessary, I mean in two situations. If the patient develops symptoms suggestive of COVID-19, or if he has acute decompensation or rapid deterioration, you don't know what is the cause. You must suspect COVID-19 infection. Streptococcal pneumonia and influenza vaccines are strongly recommended to all recipients prior to liver transplantation. What about COVID vaccine and liver transplantation? International Liver Transplantation Society recommended to to vaccinate all liver transplant candidates before transplantation. But they declared that live virus vectors vaccines should be avoided. Not only the recipient, you must also vaccinate the donors and the healthcare workers. If your potential recipient on waiting list catches COVID-19 infection, what you will do? Special care should be taken when treating COVID-19 in patients with liver disease, because we have some medications that may be hepatotoxic, may impair liver function, as remdesivir, tocilizumab. So you must pay attention and to reduce the doses of these medications. When the patient recovered from COVID-19, you must wait at least 14 to 21 days after symptom resolution and 1 to 2 negative COVID PCR test before proceeding for transplant. Last point, what to do prior to liver transplant date. First, we advise both potential recipient and the donor for a 2 weeks stay home prior to liver transplant. Then, careful history taking by phone before admission to ask the patient about the symptoms suggestive of COVID-19 infection. Nasal and oropharyngeal swab, PCR for both donor and recipient, at least once, 2 days before the operation. And it's better to be done twice, one week before transplant, and the other is 2 days before transplant. CT chest for donor and recipient on admission. Surgical consent in both donor and recipient must include the evolving risks of COVID-19 infection, including false negative results and risks of acquiring infection during hospital stay or during hospital visits. Lastly, conclusion and home messages. In spite of the limited resources and the challenges facing liver transplant in the era of COVID-19, the recommendations is not to postpone liver transplant in most centers. The decision for liver transplant is to be just tedious and must be individualized according to the local prevalence of COVID-19 and the urgency and actual clinical need in every patient. Recipient selection, if we will select who will be transplanted in presence of COVID-19, especially when we have large numbers of patients infected, you must select patients less than 60 years old and those who expected to have mortality up to 40 to 50% in the coming 3 to 6 months. Donor selection, marginal donors are not accepted at all to minimize complications and to minimize prolonged ICU and hospital stay. During the preparation of your patient, avoid frequent out-clinic visits and consider telemedicine alternative. Direct prior to surgery, home isolation for both donor and recipient for 14 days, streptococcal pneumonia, and influenza vaccines and COVID vaccine are recommended, COVID PCR and CT chest on admission, careful history taking and clinical examination on admission, and surgical consent must involve a more emerging COVID-19 risk. Last home message, this nice photo again. For these nice moments, actually, we are insisting to face the challenges. Thank you.
Thank you, Professor Mohammed, for the illustrative talk. I really enjoyed it, but unfortunately, we are very short of time, so I think we'll postpone the questions till the end of the session. It gives me a great pleasure to present my dear colleague, Professor Mohammed Saeed, Professor of Hepatology, Cairo University, and a transplant hepatologist in the team of liver transplantation, Cairo University. Please.
Thank you, Mr. Chairman. Thank you, Dr. Sarag, for inviting me to this session, and thank you, dear colleague, Dr. Nagla Zaid. I will talk about the management of liver transplant recipient and suspected or confirmed cases, real-life cases. And this is my agenda. Despite the worldwide COVID-19 pandemic, published data about liver transplantation, its outcome still scores. Since January 2020, the novel COVID-19 disease resulted in a global pandemic, making decisions about liver transplantation at its feet is uncertain. The clinical course of COVID-19 in immunosuppressed transplant recipients may differ from that in non-immunosuppressed patients. Indeed, while hepatocellular injury as characterized by elevated serum aminotransferases appears to be relatively less prevalent, acute kidney injury is more common in transplant recipients with COVID-19, possibly due to the use of calcineurin inhibitors. What about the incidence of COVID-19 in transplant patients versus general population? And this is from the Liver and Intestinal Transplantation Association and European Liver Transplant Registry, published in May 2020. And it shows that there is high risk of COVID-19 in liver transplant candidate, the cirrhotic patients, compared with the liver transplant recipient and compared with the general population. What about the severity and the outcome? Again, from these registries, they found that there is higher mortality in the liver transplant candidate and liver transplant recipients compared with the general population, but this study was in early of the era of COVID. Again, from an international registry study published in August 2020, they found that the rate of hospitalizations of patients in liver transplant cohort is higher than general population. Intensive care admission, invasive ventilation is higher in liver transplant cohort compared with the general population. But fortunately enough, they found that there is less mortality among these patients. What about the risk factors? The increasing age in liver transplant cohort increasing the mortality, the presence of non-liver cancers, the rise in the creatinine, increasing the presence of male gender, increasing the comorbidity index, increasing the mortality among the liver transplant cohort, the presence of dyspnea, and the use of mycophenolate as one of the immunosuppressive medication used post-transplant is associated with higher mortality. What about our experience? We transplanted more than 1,000 cases between different hospitals. And in Cairo University Center, we have more than 255 cases, among which there is 14 cases acquired COVID, 12 among the long-term survivors, and 2 among the recent cases, 9 confirmed and 5 suspected. Among long-term adult survivors, 7 confirmed cases by swab and or imaging. Among long-term adult survivors, 4 suspected clinically. Among long-term pediatric survivors, 1 suspected clinically. Recent transplant confirmed cases, 1 child and 1 adult. And according to the Ministry of Health protocol, this is a suspected case definition and the probable case and the confirmed case. And according to the severity assessment, when we confirm the presence of COVID, we stratify our patient into either patient with mild symptoms, normal imaging, so they required only home isolation, and patient with positive imaging and oxygen saturation more than 92% is a moderate case. If there is no risk factors, he can be isolated in home. If there is a risk factors or age above 65, he should be hospitalized. If the oxygen saturation less than 92 or respiratory rate is higher than 30, it's a severe case, require admission to the intermediate care. If there is any manifestation of respiratory failure, should be admitted to the intensive care. We have 2 children among the series, 10 males and 2 females. Age range from 47 to 68. Duration post-transplant from 6 months to 108 months. Graft status in long-term adult survivor, we have 2 patients with biliary obstruction, 1 patient with chronic rejection, 4 stable patients among the 7 confirmed cases. And the comorbidities, 2 diabetic and 1 is hypertensive. And this is the laboratory, and this is the criteria, characteristics of the 7 confirmed cases. All the patients received tacrolimus as the mean immunosuppressive. All patients represented with fever. Only 1 patient represented with diarrhea, and 1 patient is asymptomatic. And according to the WHO, there are 4 categories for severity. Either the patient is non-hospitalized or hospitalized with mild disease or hospitalized with severe disease. And according to disease classifications, our patient, we have one patient with WHO score 6 and one patient with WHO score 4, and both of them showed elevation in the creatinine, and both of them showed significant infiltrate in the imaging with COViD 5. 4 of these 7 cases required hospitalization, while one patient refused to be hospitalized. And these are examples for the infiltrate in the imaging. And according to the management plan and management protocol, according to the Ministry of Health, if we have a mild case less than age of 65 without risk factors, only single management plan is home isolation and paracetamol. If we have a patient with risk factors or age above 65, we have 2 management plans, antiviral and conservative medications and vitamins. If I have a patient with a moderate case, we administer antiviral in addition to immunomodulatory medications, mainly steroids, in addition to anticoagulation. If the patient admitted to the hospitals, to the intensive care, we have the 4 management plan: antiviral, anticoagulation, anti-inflammatory, and escalating the management to receive tocilizumab, in addition to the administration of convalescent plasma. Our patient, 2 of them received oxygen, 1 of them received mechanical ventilation. These 2 patients required modification of the immunosuppression and required either oral or intravenous steroids, and only 1 mortality. In summary, we have 4 patients out of these 7 had mild disease. 3 out of these 7 had moderate to severe disease. 4 of them required hospitalization. 6 among the 7 long-term survivors had confirmed COVID-19, they are improved. Another 5 suspected clinically improved. 2 confirmed cases among the recent transplant recipients, they improved, and only 1 mortality among the 14 cases. And usually the management is a multidisciplinary management between the liver transplant hepatologist and the pulmonary consultant and intensive care consultant. And my closing remarks, COVID-19 pandemic had a significant impact on liver transplant activity in a majority of centers. Liver transplant candidates and recipients are both at high risk for COVID-19 infection that could potentially be higher than the general population. A prompt early screening of COVID-19 symptoms among liver transplant candidates and recipients and proactive management is necessary. Male gender, advanced age, comorbidities, and mycophenolate were associated with SARS-CoV-2 COVID-19 mortality in liver transplant recipients. Modification of immunosuppression is not mandatory in most of the cases, except for mycophenolate should be discontinued. Although incidence of SARS-CoV-19 could be higher in liver transplant recipient, but mortality could be same or even lower than the general population due to possible protective effect of the chronic immunosuppression. This is our Cairo University team. And this is our first round of the Qasr Al Aini Consortium of Liver Transplantation Education and the Qasr Al Aini School of Liver Transplantation, which is under foundation. And this is the consortium board. And we are planning for the second round in next June, inshallah. Thank you.
Thank you, Professor Dr. Mohammed Saeed, for this illustrative talk and the cases from clinical practice in Cairo University. Now it's my pleasure to introduce to you my dear colleague, Dr. Iman Fawzi Montasir, Professor of Tropical Medicine and one of the transplant hepatologists in ASCO team. She will also present real cases from Ain Shams University.
Thanks for the organizing committee for this kind invitation. My agenda for today will be the COVID-19 current situation in Egypt, COVID-19 and transplantation, and the management of liver transplant recipients with non-COVID-19. The situation in Egypt until today morning, Egypt had more than about 197,000 confirmed cases and about 12,000 deaths. And the situation in Egypt, most governmental and university centers have temporarily discontinued their transplant activities based on unacceptable donor risk, as we have only living donor liver transplantation, and the uncertain data on the impact of COVID-19 on recipients, and also to reserve the resources for the management of the pandemic. In our center, Ain Shams University hospitals, we temporarily held the program from March till the July 13th. And although the operations were temporarily held, the outpatients follow-up clinic had continued, and I claim that our staff had made great efforts to follow up the recipients, whether through the telemedicine and or the hospital visits whenever needed. This is our transplant activity over the last 10 or 11 years. And as we can see, we have about 30% reduction in transplant activities in 2020. For the non-COVID cases, we try to give health education. All patients and recipients are instructed not to stop or reduce their immunosuppression doses by themselves. This is a very important point, as some of our patients have wrong information to stop or reduce their immunosuppression doses. The general rules of social distancing, the follow-up of any respiratory symptoms, and immediate notification of the liver transplant team. History of contact with suspected or confirmed cases are also recorded. For the vaccination, the regular vaccines, as recommended by the AASLD for recipients are advised to vaccinate against the streptococcal pneumonia and influenza vaccine, capsular polysaccharide and killed vaccines, and to strict traveling for any unessential needs. For the COVID vaccine, as Professor Mohammed mentioned, I will go through it rapidly, that live attenuated vaccines are not appropriate for liver transplant population. This is the statement released in January 2021 by the ITS. And the consideration should be given for vaccination of liver donors, as Dr. Mohammed mentioned, and the healthcare takers and givers. I'll go through it rapidly. And as Professor Gish had just mentioned, this data just published in March 15th, 2021 on the immunogenicity of the messenger RNA vaccines. The two vaccines used in the US are Pfizer and Moderna. This is data on solid organ transplant recipients of 187 cases, and they reported no episodes of acute rejection, new SARS-CoV diagnosis, or neurological adverse events or major allergic reactions, and they strongly recommend to reassure all recipients for vaccination. This is another data just published in March 2021. Dr. Gish, I think, mentioned it on 136 cases, and he mentioned that the immunogenicity was only 17% of cases, and that the two risk factors, they found that the immunosuppression with MMA or MMF and the older recipient age was less likely to develop the antibody response. For the post-transplant clinics and follow-up, the patients are followed up, those who were transplanted more than 3 months are followed up through telemedicine, mainly through telemedicine. Hospital visits and admission are limited for those in need for it according to the transplant physician judgment. For the early post-transplant period, less than 3 months, regular post-operative follow-up visits are recommended per center protocol. We tried to limit the number of patients to do the routine precautions of distancing, hand hygiene, the facial masks, and so on. This is very important data from the Italian experience on the telemedicine. And they found in this survey that the attitude toward telemedicine in 153 liver transplanted recipients, that about 62% of recipients would use the e-health technologies instead of the face-to-face or the physical follow-up in absence of relevant health problems. Another data on the telemedicine from the US from April 2020, we can find that about 85% of the clinic visits were converted to virtual meetings or virtual visits during the second wave of COVID. And pre-transplant liver evaluation clinic visits were conducted virtually between the transplant hepatologist and the surgeon. For the admission and endoscopy workup for the non-COVID patients, hospital admission was very limited scale, and patients on waiting list, those presented with emergency like hematemesis, SBB, hepatic encephalopathy. For the endoscopy workup, we do only urgent endoscopies till July 2020. Then we restarted the regular endoscopies and ERCP for biliary complications. And of course, all patients are tested for COVID infection before admission. This is one of our real life cases. She's a female patient, 50 years old. She received liver transplantation on the 2nd of August 2018, about 2.5 years, for HCV related end-stage liver disease. She's child C, mild 15, previous history of interferon ribavirin therapy, and she was relapsed. She had HCV RNA BCR of about 1 million before transplantation. The operative data, she had a very smooth post-operative period, graft recipient weight ratio of 1.3, the amount of ascites drained of 7 liters. She just only had biliary complications, biloma on day 12, and was managed conservatively. She was discharged on tacrolimus and tapering doses of steroids. The patient was on irregular follow-ups, and she came on September 2020 with elevated liver functions. She admitted of stopping the tacrolimus for the last 3 months by herself. This is her initial laboratory data, and we can see that the bilirubin was about 10, AST and ALT 950 and 620, and elevated alkaline gamma GT over 1,000. The ultrasound show homogeneous graft, patent vessels, no intrahepatic biliary radical dilatation, and no ascites. By the way, her trough level, FK trough level was below 1.5. The patient was admitted for hospital. We decided that this case needs admission. It cannot be managed at outpatient, and we did further investigations. So the differential diagnosis was open for acute cellular rejection, of course, on the top, chronic rejection, biliary problems, HCV recurrence, and other possibilities like COVID infection. We did liver biopsy together with the virological workup. The liver biopsy showed acute rejection, moderate score 6/9, associated with moderate cholestasis. Her CMV BCR was negative, HCV BCR of 4 million, and hepatitis B surface antigen was negative. So we decided to go parallel, hit both the rejection and the HCV recurrence. We started pulse steroid together with the initiation of DEAs. And addition, she received pulse steroid for 3 days with maximizing the immunosuppression, MMF, together with increased TAC level. And at the same time, we started soft lady DAAs. This is her regular follow-up since then. Until the last week, she had normal bilirubin in the last visit. This is her first lab after pulse steroid and DAAs with reduction of both bilirubin enzymes. And this is last follow-up after finishing her DAAs. She had undetectable BCR, normal bilirubin, normal liver enzymes. However, the alkaline gamma GT is still elevated. For my message for this presentation, that many questions remain. Management of the non-COVID transplant recipients and patients on waiting list is very crucial. Regular immunosuppressant doses are very essential, And every effort should be made not to compromise the management of these vulnerable patients during the pandemic. Telemedicine follow-up is expected to continue during the next future, and more burden on transplant teams is required for follow-up of such cases. At this point, I end this presentation. Thank you all, and I'd like to thank all my colleagues in ASCO team, ANSHAM's team. Thank you very much.
Thank you, Professor Dr. Iman, for this informative, interesting presentation. So I think we can have one question for each speaker. Any question?
Yes, please, Nagla. If there is a Professor Mohammed, I would like also to thank all speakers for the elegant talk, but specifically, you clarified that if patients on the waiting list who developed COVID, you clarified that it's enough to pass about 14 to 28 days to be safe to transplant these patients. So I would like to know, in your own experience on the waiting list, how many cases in your institute developed COVID while on the waiting list, and what was their outcome following liver transplantation?
Fortunately, sir, we have no patient on our waiting list developed COVID-19 infection.
Okay. Any of the colleagues have any experience specifically in this part? From ANSHAM's Professor.
Patients having COVID on the waiting list, before transplant on the waiting list? I mean, the outcome, I think the treatment, the outcome, what about
yes, we have 2 cases of COVID-19 infection on the waiting list. One patient was discovered accidentally while he was prepared for the operation, accidentally by PCR swab before admission to hospital. And he still has the PCR positive after 2 weeks and after 1 month. Although he's asymptomatic, but we delayed the operation. We decided to delay the operation. He and his donor both are positive, asymptomatic.
Okay, thank you. I think Dr. Sharif, we have to know if the patients have more aggressive course, but the carriers that we took them during preparation, yes, we have like this, but they are almost asymptomatic. But yes, fortunately, they are carriers. But as for most of the patients who are immunocompromised, I think if they have the infection and it's moderate or severe, it will be a very bad outcome. But what we have a lot more than the number that Professor Mohammed presented, the patients who have infection post-transplant. Fortunately, we have a big field, so we have lots of patients who have the infection post-transplant. And very fortunately,
unfortunately, can you just, the intensity of the voice is very low. Can you just clarify what you're saying, please?
I think there is a problem.
Yes, the voice.
For the patients who had the infection post-transplant, the course was much simpler than the naive patients or the patients who are not under immunosuppression. And I think this is because the cytokine storm was much more or less in those patients because of the immunosuppression. So this is fortunately, maybe I have more than 50 patients who had COVID. Death was only in 2 of them, and because of pulmonary embolism, but most of the patients passed smooth.
Yes, because in our experience, patients who developed COVID post-transplantation, really they had a very mild course, and most of them went very smoothly. And most of them, as Mohammed Saeed has clarified, were mild to moderate. But patients on the waiting list who develop COVID, I think maybe 2 or 3 weeks are not enough to bypass to make them safe to a transplantation process. Can Professor Robert give us his opinion on this aspect, if possible?
Yes, I think this really needs to be individualized depending on their pulmonary status. Do they have a systemic inflammatory response? Is there any other long-term impact of the infection? What's their PCR status? Importantly, what's their rapid test status? I think you have to integrate across all these different factors: frailty, nutrition, stage of their liver disease, urgency for transplant. So I don't think there's one answer, but I think these presentations were fantastic and really will allow us to individualize our care.
Thank you.
question, Professor Nagla, regarding nowadays the cases are increasing in number, and in the other centers here in Egypt, like in Shams and others, do they slow down again these days, or they will go on the same?
Asking, did the other centers transplantation process with the cases increasing?
Yeah, I think
the second waves.
A third wave.
Professor Mustafa, I think all centers slowed. How are you? All centers slowed the activity initially, the same that happened all around the world. But I think as we became more confident and we had a roadmap in dealing with COVID pre-transplant and post-transplant, we've all taken back our initial activities. But I think what we come out of this session really is there are still a lot of unanswered questions. And what scares me personally is the circulating carriers around that we don't know. And because we don't screen very well, we have a problem with the asymptomatic carriers that are moving around, especially in the medical personnel, even us. And we don't screen the surgeons, we don't screen the nurses, we don't screen the physicians. And this is a very worrying thing. And if you look at the experience from the US, they definitely screen their staff. And I would like to ask Professor Robert Gish, do you exclude staff who show a positive PCR? And for how long do you exclude them?
So I think the PCR answers really moves to not testing with PCR once the patient is asymptomatic, pulmonary symptoms have resolved, afebrile, no systemic signs of infection. Rapid test is good, that's negative, and then you just wait 7 to 10 days in a normal immune competent individual. So it's more time in following symptoms because PCR has this extreme sensitivity for viral fragments and doesn't indicate actively replicating virus or that they're infectious.
So
I gathered from Professor Rifat that he is asking about screening for the staff, the surgeons and the nurses and so.
Yes, right.
So screening takes place prospectively in asymptomatic individuals, and it depends on the center. It could be weekly or up to thrice weekly. It also depends on the background infection rate in the community. Some areas in the US are well under 1% now, and testing frequency falls off. And then of course, if individuals have been exposed, there's maps by center. In Loma Linda, I get a notice every 2 to 3 days about a potential exposure. And there's also geographic maps that are apps on phones that are region specific. So that would influence testing frequency.
Thank you.
So I think we've come to the end of our session. Really, transplantation in the era of COVID is a very challenging issue. We should adopt our own policy, our vigorous and aggressive policy that can use in the context of our resources. And we hope that our patients and our physicians and our staff are all in safe. So by the end of this session, I really would like to thank my dear chairpersons, my dear colleagues, my dear speakers, Professor Dr. Gish, for their kind acceptance to share in this important session. Thank you very much. I have another announcement. Lunch or even dinner is in قاعة النيل.
ناخد الغدا فين يا نجلاء احنا؟
Thank you very much. Thank you.
كله فيرتشوال يا دكتور مصطفى. الفيرتشوال الى الاخر.
بقول لك اي حاجه اهو.
ربنا يطمنا عليك. نشوفك على خير يا دكتور مصطفى. السلام عليكم. السلام.